Of the Obstetrician and Gynecologist articles, which is an ideal resource for your continuing professional development in women's health. Today, we are here to tell you about the smoking in pregnancy, the pathophysiology of harm, and current evidence for monitoring and cessation. It is the talk article published in July 2019. The cigarette smoking in pregnancy has an adverse impact on maternal and fetal health. Smoking cessation is advocated to eliminate this risk factor and improve the pregnancy outcome. Smoking has long been associated with increased rates of miscarriage, stillbirth, placental abruption, preterm birth, and low birth weight. In England, the prevalence of smoking at the time of delivery has steadily declined from 15.1% in 2006 to year 2007 to 10.4% in the first quarter of year 2018, with a target of 6% or less by year 2022. Smoking strongly correlates with low socioeconomic status and is a major cause of the health and life expectancy inequalities encountered by women from deprived backgrounds. The pregnant smokers are more likely to be younger, be unemployed, have low educational attainment, have a lack of social support, and have increased incidence of mental illness. Women experiencing depression are 4 times more likely to smoke than other women, and thus presents a challenge to smoking cessation services. So what is the pathophysiology of harm from smoking? Cigarette smoke is a complex, heterogeneous mixture of more than 4,000 compounds, including nicotine, carbon monoxide, carcinogens, and heavy metals. In pregnancy, the cigarette smoke negatively impacts the fetus, globally restricting the supply of oxygen and nutrients, altering its growth and affecting the development of organs such as the brain and the lungs. The carbon monoxide. A smoker is exposed to 400 to 500 parts per million of carbon monoxide over the time taken to smoke a cigarette, producing a baseline carboxyhemoglobin of 4%, in contrast to 1% in the non-smokers. As the concentration of carbon monoxide increases, there is a left shift of the oxygen-hemoglobin dissociation curve, reflecting the greater affinity of hemoglobin for carbon monoxide. This left shift impairs oxygen delivery to the myometrium and fetal placental unit. TAR. TAR damages the respiratory tract by mechanical and biochemical mechanism. It also contains carcinogenic compounds such as polycyclic aromatic hydrocarbons, the aromatic amines, and nitrosamines. These compounds interfere with biochemical pathways and macromolecules, leading to a pro-inflammatory state with widespread oxidative damage. The heavy metal cadmium in cigarette smoke is associated with fetal growth restriction. The nicotine is an addictive alkaloid derived from tobacco and is a potent stimulant of the parasympathetic nervous system. It readily crosses the placenta and has a direct effect on the fetus and the placental vasculature, in addition to its effect on the maternal circulation. Nicotine has been classified as a neuroteratogen and is known to disrupt neurotransmitter function in the fetal brain and altering the normal brain development. The NICE recommends that all pregnant women be asked about their smoking status at their maternity booking visits and at regular intervals during the pregnancy and the puerperium. It also recommends biochemical screening of all pregnant women via exhaled carbon monoxide. Currently, in the UK, a midwife or health support worker administers the exhaled carbon monoxide test to women presenting for their booking appointment. Now, all current smokers, occasional smokers, and smokers who have quit in the previous 2 weeks are referred to their local NHS stop smoking services on an outpatient basis. Women with high exhaled carbon monoxide levels, that is greater than 4 parts per million, who deny smoking are referred to NHS stop smoking services for advice on second-hand smoking and smoke-free homes. The non-disclosure of smoking status during pregnancy prevents women from accessing the appropriate smoking cessation support and can lead to significant underestimation of smoking prevalence. Health support workers have found universal carbon monoxide screening easy to implement and well received by women, with screening now seen as part of the daily routine. The cessation rate in pregnancy is much higher than that of the general population, with between 27% and 47% of smokers quitting with the first trimester. Many women report quitting spontaneously when pregnancy is confirmed, often within the first few days. So women who quit in early pregnancy are more likely to maintain a cessation than are those who quit later. What does the talk article say about the postpartum relapse? Unfortunately, there is a high rate of relapse, with many women smoking again before the end of pregnancy and in the early postnatal period. Less than a third of spontaneous quitters in pregnancy remain abstinent 1 year postpartum. The breastfeeding mothers are less likely to relapse, and women who are single, who are parents, who have a partner or household member who smokes, those with high depression scores, and those with a heavier smoking habit pre-pregnancy are most likely to relapse in the postpartum period. So you all need to remember the 5 A's for brief smoking cessation interventions: the ask, the advise, the assess, the assist, and the arrange. So the states of SANES, starting from the pre-contemplation to contemplation to preparation to action to maintenance and relapse, it completes the cycle. So what is the nicotine replacement therapy? The nicotine replacement therapy, it seeks to replace the cigarette smoking with its harmful tar, the carbon monoxide, and other compounds with clean nicotine delivered in a safe manner. The dose of nicotine replacement therapy is gradually reduced until a user can stop the therapy without excessive psychological or physiological withdrawal symptoms. The nicotine undergoes the first pass metabolism in the liver, limiting its oral bioavailability. The nicotine replacement therapy is therefore delivered via mucosal or the transdermal routes. These are available in the form of transdermal patches, the lozenges, the chewing gums, the oral sprays, the microtabs, and the inhalers. The transdermal patches deliver the nicotine slowly over the course of a day, and in contrast with the other products that are faster acting and aim to counter acute cravings. The accelerated metabolism of nicotine in pregnancy results in lower serum concentrations of nicotine and its metabolite cotinine, making sufficient doses of nicotine replacement therapy an issue in a pregnant population. It is a proven method of smoking cessation in non-pregnant adults, with an increase of 50 to 60% in cessation rate, regardless of the setting. The electronic cigarettes, they use a battery-powered elements to heat a solution of water, propylene glycol or glycerine, nicotine and flavorings. The electronic cigarettes use results in a rapid rise of serum nicotine levels, reaching higher values than those achieved by nicotine replacement therapy. The use of electronic cigarettes mimics the behavioral and psychosocial aspects of conventional cigarette smoking without the associated harm. The electronic cigarettes do not contain tobacco and do not combust their contents. Approximately 5% of the adult population in England use electronic cigarettes, with their use increasing year on year. So the decline in the prevalence of cigarette smoking has been mirrored with the rise in electronic cigarette use among adults. The most frequently cited reasons for using electronic cigarettes are health, wanting to cut down, and wanting to quit smoking. The concerns have been raised that electronic cigarettes may renormalize smoking or perhaps lead to non-smokers taking up smoking through a gateway drug effect. There is a lack of safety data on the use of electronic cigarettes in pregnancy, and their effectiveness for smoking cessation in pregnancy has not been established. So in the United Kingdom, Helping Pregnant Smokers Quit is a National Institute for Health Research multi-center randomized controlled trial currently recruiting pregnant smokers for a clinical trial comparing the electronic cigarettes versus the usual care, with the results expected in 2021. So the talk article concludes by saying that smoking in pregnancy is a major preventable risk factor for maternal and neonatal morbidity. The maternal smoking rates are declining, with a higher proportion of continued use encountered in lower socioeconomic groups. The harm from cigarette smoking is primarily from carbon monoxide and tar, which contribute to the complications seen during pregnancy. The nicotine alters the fetal brain development and contributes to behavioral disorders in the offspring of smokers. The relatively high smoking cessation rate in pregnancy is tempered by a high rate of relapse in the postnatal period, with less than 1/3 of spontaneous quitters remaining abstinent at 1 year postpartum. There is a lack of safety and efficacy data on use of e-cigarettes in pregnancy, and no data on obstetric outcomes in pregnant users. However, women perceive them to be less harmful than cigarettes. Further research is needed on pregnancy-specific cessation methods as well as methods of preventing the postpartum relapse. So from this talk article, it is important for the MRCOT Part 3 preparation to handle the role player. For this, you need to know the steps of the smoking cessation program.